Ready?
Yeah, it's rolling.
You're rolling.
Yeah. Hello, everybody. Welcome back. We are at the NEC Symposium. We're joined today with Dr. Martin Blakely. We're going to go on a first-name basis. Jen Canvasser was very strict about calling everybody by their first names. Martin is a professor of pediatric surgery and pediatrics at Vanderbilt University Medical Center. Martin, thank you for being on with us today.
Yeah, thanks for being here.
So you are speaking at the NEC Symposium about optimizing surgical treatment for NEC. Can you tell us a little bit? How do we do that?
Yeah, so I'm a pediatric surgeon, but I've also been very interested in clinical trials. So from the very beginning, I've been interested in comparative effectiveness research. So if one surgeon does treatment A and one surgeon does treatment B, I've always been very interested in why is that and what are the outcomes of that. So I'm going to be presenting today 3 randomized trials that have been done in the neonatology pediatric surgery community, looking at the initial choice of laparotomy or drainage.
Very cool. And in terms of, I think that's a question that we've been asking about for a long, long time.
And we feel it clinically.
Absolutely.
But, every time we have a patient. Right?
And where do you think we are in terms of either dissociating the two, or at least, because it feels like a lot of times it's drainage sometimes, then laparotomy.
Mm-hmm.
Right. Do you think that we are getting closer to a place where a drainage will be sufficient?
I don't think so. So sort of my quick summary of that, trials that have addressed that question. So again, what should the surgeons and the neonatologists do at that initial consult when a child has either NEC or SIP?
Right.
So there are 3 trials that address that. I would be surprised if there's another trial that addresses that question. I could be proven wrong, but I think where we are now is the latest trial, which is called the NEST trial, was the first one that looked at the impact of what the diagnosis is on that treatment question. So we had 2 trials before which did not get into the weeds of whether you had NEC or SIP. And both of those trials showed that there was really no difference in these very different surgical procedures. So we all argue about lap or drain, but we have 2 studies that when you look overall, it looks like, well, it really doesn't make a whole lot of difference in mortality. But the last trial, which is more complicated because it does consider NEC or SIP, and I think, I'm biased, but I think it pretty clearly shows that if the neonatologists, the surgeons, put their heads together and say this baby has NEC, then laparotomy's better. And if you put your heads together and you think this baby has SIP, there's much more uncertainty around that. The data from the trial showed that maybe drainage is better. So again, I think we have moved the field forward, I think, from looking at overall lap and drain to knowing the importance of the impact of the pre-op diagnosis of NEC or SIP.
Yeah, that study kind of used the pretest probability of were you right or wrong about the diagnosis and how successful was the outcome. But it begs an important point. I think we're always looking for what's the treatment that helps the most babies. But I think we keep landing on that every baby is a little unique and it depends on the diagnosis. I also wonder, as a surgeon, are there certain characteristics about babies that might make you lean one way or another and might make the outcomes better, based on what's already going on with that individual baby?
Yeah, I think that's a really good question. So again, I think, no trial answers all of the questions that we have. So the NEST trial, I think, was a big advance because it got us away from looking at overall groups into the now NEC and SIP group. One of the things it did not answer, though, is a lot of surgeons pick whether to do laparotomy or drainage, not based on pre-op diagnosis, because maybe they feel like they can't make that diagnosis accurately, but they choose weight. So like the tiniest babies with a very low weight, more likely will get drainage. And then the really sick baby, so acuity of illness is another way to sort of divvy up those therapies. is another thing people use. So what NEST, a limitation of the NEST trial was it did not look at the impact of patient weight at the time we're making these decisions or the acuity of illness. So in a tiny baby who's super sick, how does that influence whether laparotomy is better or not? So we are just now, even though the NEST trial was published back in 2021, we're just now looking at secondary analyses that will give us those answers. So I think there's more to come on dialing down precisely who a laparotomy is better for and when you should hold off on that and probably do a drain first, knowing that you may get to lap next.
We've been asking this question to every individual who's dropped by the mic, and as Jen Canvasser eloquently presented at the beginning of the conference, what is the reason why it is important for you to present this topic, present this research here at the NEC Society? Well, obviously it's related to NEC, but like you could present this at any other conference. Why is it important for you to be here?
Yeah, so I am very passionate about the NEC Society, so I'm a board member, very happy and proud to be doing that. I feel like I've got another 15, 20 years in my career, and I really want to focus on improving the outcomes of NEC babies with research. And another point is, even though I'm a trialist and I talk about trials a lot, I have sort of, in the last year or so, become more and more interested in the impact of our trials because we don't really know how often those trial findings get implemented into practice. Right. We also know, and one of my messages here at this meeting with all the family involvement is no family is seeing the publication of any of these trials. We don't present our findings in a way that's meaningful to them. So I'm looking to learn from them, okay, the next trial we do, how can we get you, the family, or like let's say the bedside nurse, or all these people that they're off the radar of how.
And they're integral in the care of these infants.
Yeah, I mean, they impact the care. They probably have a lot of influence over what sort of treatments babies are getting because they know the families, they talk to the families. But they are totally off of our radar on disseminating and sharing the results of trials. So I've really gotten into implementation science over the last year or so. So that's another thing I really want to share with the group here.
Very cool.
Yeah, I think the last time we presented on it, the data showed that from study publication to like protocol design is something between 15 and 17 years. And so I guess to your point, how important is it then that we are collaborating, reaching across the aisle, so to speak, neonatologists and pediatric surgeons and other subspecialists to move research faster?
Yeah, I mean, I think it's critical. I mean, again, there's so many different questions we haven't talked about, like the use of ultrasound, to help with the diagnoses. And then that obviously includes a whole different group of providers, right, like radiologists. But so again, I think you can't do any of this work, I don't think, in a meaningful way if it's just from a surgical perspective or a neonatology perspective. This has to be a team sport, I think.
Thank you so much, Martin, for dropping by and sharing your thoughts with us. We wish you best of luck on the rest of the conference, and see you around.
Great. Thank you so much.
Thank you.
Thank you.